Many thanks, dear professor. It's a big honor to have you. Dear Dr. Nuria, how are you? It's a big chance to have you too. Nice to meet all of you.
Thank you very much. Nice to meet you. It's a pleasure for us to participate today with us and to share with you our experience in pediatric heart transplant.
It's the pleasure and the honor is for us, of course. And also, dear Dr. María-José Santiago, we are really pleased to have you.
Thank you. Thank you to also. And I'm sorry, I have to do this at home.
No
so
problem.
I hope the sound is okay.
The sound is awesome. Everything is okay. If you agree, we are going to start the session. Our first speaker, we are going to be Dr. Nuria Gil-Villanueva. I just want to share the information. She is consultant pediatric cardiology in Gregorio Marañón Hospital, Madrid, Spain. She is a pediatric cardiologist and works in Hospital Gregorio Marañón since 2008 on the pediatric cardiac ward. She also works in pediatric heart transplant unit since an advanced heart failure in 2013. She also has experience in congenital heart diseases. It's a big honor to have you here, doctor. I'm going to share the presentation with dear audiences, and then please keep your microphones off, keep your videos off, please. As a participant, if you have any question, you can ask in the chat section, and after I'm going to share with the speakers. Thanks a lot.
Afternoon. My name is Nuria Gil. I am one of the pediatric cardiology in Hospital Gregorio Marañón in Madrid, Spain. And I belong to the pediatric heart transplant unit with my partner Esther Panadero, who is an intensivist and the leader of this unit, la doctora Camino. And today I want to share with you our clinical practice with this type of patient, pediatric heart transplant. As you know, a heart transplant is a surgery done to remove the diseased heart from a person and replace it with a healthy one from a donor. As we say to the parents, we change one disease for another, but with a good quality of life. What does a center need to perform a pediatric heart transplant? For performing a pediatric heart transplant, you need a multidisciplinary equipment, as you see, with all the staff, doctors and nurses with experience in congenital heart disease. In our hospital, we have a pediatric cardiac surgery, pediatric cardiology, and PICU unit with experience in pediatric heart transplant and VAD, and with a high activity each year on this field. But we also have a cath lab, microbiology, immunology, pathological anatomy, and all the pediatric specialists which can help us in the management of these patients. Also, in Spain, we have a national organization of transplant that controls all the centers implicated in transplant and the waiting list. Children who need a pediatric heart transplant are children with cardiomyopathy, especially dilated cardiomyopathy, or congenital heart disease, mainly hypoplastic left ventricle syndrome, who are in a situation of cardiac failure with no medical or surgery treatment. When a patient is in one of these situations, we begin to work. In the receiver evaluation, we review the clinical history, especially cardiology history, previous surgeries, catheterings, image proofs, echo, TC, MR. We review the NIHA class and the treatment. Also, we have to check the vascular access by catheters for the surgery. Also do a lot of blood samples, as I saw in this image. Especially we do a coagulation test for the surgery, but also a complete evaluation of the immune system with a main importance of the presence of circulatory antibodies, and we check the blood type and the presence of isoagglutinin. Also, we have to do a complete evaluation of the patient because we are not only heart, as you know, in order to check if there is any contraindication for heart transplant. By the time we have checked all the items, we show the patient in a session with all the equipment, and we decide if the pediatric heart transplant is the best option for this patient. At that moment, we send the data of the patients to the National Transplant Organization, and we put in the medical history the protocol of immunosuppressive treatment and other things if there are something special, in order to everybody in the hospital know what to do after transplant in every moment. From this moment, the patients are included in the waiting list, but although Spain is the world leader of donors, this waiting list time lasts around 2 months, a median of 2 months. This time usually is longer for children under 1 year, because we are waiting a miracle that a donor appears. We are waiting for a heart of a proper size, 1:1 or 3:1, of difference from the donor to the receptor, and a heart of the same blood type. This condition is avoided in children less than 1 year with the AVOI transplant, as I will explain you at the end of this. This is the distribution criteria of organs in our country. We have these urgency levels. Children with VAD or ECMO are in the top of the emergency list with an urgency 0. After them are waiting the patients who need inotropic supports, the failed fountain, and patients with restricted cardiomyopathies with high pulmonary vascular resistance. The patients with no have one of these conditions are on the waiting list in an elective manner. Depending the condition of the patient, they can wait their new heart in the PICU unit if they need inotropic support or VAD in the hospital, but on our ward, if they need monitoring or less inotropic supports such as milrinone or levosimendan, or they can wait at home as outpatients if they only need oral cardiac failure. In the waiting list time, the receptors must be near hospital in the same city of our in the same city, in order to guarantee a near follow-up, but also they have to come to the hospital in less than 1 hour if there is a donor. This is a very stressful time, and the patients and their family usually need psychological treatment and important social supports. In this period of time, also rehabilitation and nutritional treatment should be good in order to avoid descompensation of these patients with respiratory infections or with anemia. And we have to guarantee in all the time a correct cardiac failure treatment in order that our receptor goes to the heart transplant in the better manner as possible. This treatment should be in NICA class 1, 2 oral treatment with YEC gas, beta blocks, spironolactone and furosemide, ivabradine, or sacubitril valsartan in different proportions and doses. If the failure is more advanced, we usually need endovenous treatment with diuretics, or we use a lot milrinone and periodic infusions of levosimendan in an ambulatory or on the ward for these patients in the waiting list. If the NICA class advanced to a level 3, 4, sometimes milrinone is not enough for this patient, and we need support with adrenaline. And in the last studies, or ECMO, these patients weight their heart in the PICU unit, and in some times we need in the worsenings to do surgical procedures, or we have to use resynchronization therapy, as you see in the previous. And when the miracle happens and we have a donor, the National Transplant Organization called us to the mobile phone of the Pediatric Cardiology on call. They explain the characteristics of the donor, and we call to the Pediatric Cardiac Surgery team, and together we decide if the donor is correct for us. At this moment, we begin a lot of coordination calls. The Pediatric Cardiac Surgery advise all the equipment related in the surgery, anesthesia, perfusionists, nurses, and we call festival to the family and the patient, and also we call to all the staff implicated in the process, such as a PICU unit, if the patient is at home, the pediatric cardiology ward, also hematology, immunology, and all of these activities are made in order to do all the procedure in the less time as possible to reach a time of ischemia less than 4 hours. I will not explain you the surgery because Dr. Jaurena will explain you later, but as the same as other heart surgery, the children later go to the PICU unit. They usually need inotropic support. We can use dopamine, adrenaline, plus milrinone, weekly levosimendan infusions to help to recover the left ventricular functionality. We also use isoprene to guarantee sinus rhythm during the first week, more or less. We usually use nitric oxide and sildenafil to help to the right ventricle, which is the one that suffers more during the surgery, during the ischemia period. And the complications we can see in the first days are the same of other heart surgery, such as diaphragmatic paralysis, bleeding, prolonged mechanical ventilation, deferred external closure, especially if the donor is bigger than the receptor, or sometimes we need hemofiltration because of renal failure. After the PICU time, the patients go to the ward. We have a pediatric cardiology ward with all the staff with experience in pediatric heart transplant and with a central monitorization. During this stay, the children usually need rehabilitation and nutritional treatment, and it is very important the action of the nurses and our action, of course, because pediatric heart transplant, as I have said, is like other heart surgeries, but the difference is that now they have another completely different disease, and they have to understand it and understand all the new medication, immunosuppression medication especially, and their new condition. And for that, we have to do a good sanitary education with special recommendations for these patients. We always give them a mobile phone of us that it is for them, for their families and their pediatricians or cardiologists in other countries to call us for any doubt or any problem. And this mobile phone is open 24 hours per day and every day in the year for them. So the most important characteristic of the most important medicine that we give to the pediatric heart transplant till the time zero or before the surgery is the immunosuppression therapy, because from these medicines depend the life of the patient. I will show you our protocol, but it will be different in other centers. We previously used induction therapy with basilizumab, but we have stopped this therapy from 2016 with good results because our investigation of the immune system. And we use tacrolimus, MMF, and corticosteroids as the immunosuppression therapy from the beginning. In the follow-up, this immunosuppression, it could be changed. We usually withdraw the corticosteroids from 6 months or 1 year post-transplant, if it's possible, if there is no risk factors for rejection, and we maintain the patients in a double therapy, most of them with tacrolimus and MMF. Some little patients could be in the follow-up with a monotherapy, but there is less of them. And we usually, if they have history of rejection, we maintain corticosteroids. We can add or change MMF to sirolimus therapy in the graft coronary disease. And the most important is to make the patient and the family understand that these medicines maintain their lives and monitor the adherence to immunosuppression treatment in all moments with these patients to ensure a good adherence to the treatment. What are the morbidity that we have to look after in these patients? This is a graph of the ISHL team, where you can see that the graft failure could be present from the beginning in the high manner, but during the first 3 years after transplant, the acute rejection is the morbidity that became more important. It could be cellular acute rejection. As I have said, it is more frequent during the first year after transplant till the third year, and especially after stopping corticosteroids. So usually 1 month after this stop, we do always cardiac biopsy if it's possible. The symptoms of acute rejection in children are very inspecific: fever, vomiting, stomachache, dyspnea, weakness. So during the first years, if a pediatric heart transplant has fever, we have to evaluate him with blood samples, tacrolimus levels, ECG, echo, and sometimes we have to monitor them, although they have only fever, and it finally has some virus infection. But during the first year especially, we have to look after rejection in all the symptoms because they are very inspecific. And if we suspect rejection, we have to treat with methylprednisolone bolus, 10 milligrams per kilo doses each day during 3-5 days. Also, we have to treat acute severe rejection with thymoglobulin. Another type of rejection, humoral rejection, this is a rejection mediated by specific anti-donor antibodies in the blood. It is more frequent in patients with prior transfusions, prior surgeries, congenital heart disease, or VAD, but it will appear in all the patients. And this is a rejection that it is difficult to diagnose because it usually appears not with left ventricle dysfunction, severe dysfunction, but yes with a restrictive manner of the heart to work, and it has a difficult diagnosis but also a difficult treatment. We have to do apheresis techniques in order to reduce the antibodies in the blood, but also we give immunoglobulins, rituximab, bortezomib, and a long time treatment with not always good results. So if we suspect a rejection, we have to treat it, I have said to you, and we have to monitorize the patient to check if they have arrhythmias. We have to do ECG, echo, and blood samples to titer tacrolimus, and also we usually check the VNP or similar because it will rise if we have rejection time. And to confirm the diagnosis, we have to do catheterism with a myocardial biopsy and coronarography in order to check in the vascular disease, and we can calculate cardiac output. And if we suspect, we treat. The other side of the immunosuppression therapy, which we try to avoid the rejection, is that we make appear some infection. In the same graph of the ISHLT, you see that again during the beginning, from the beginning to during the first 3 years, infections are the most frequent morbidity. During the first 6 months after transplant, opportunistic infections are the most important, And after these 6 months, community infections becomes more important. In children, viral infections are the more frequent. We give prophylaxis to all our children with valganciclovir to avoid cytomegalovirus infection, nystatin for fungal infections, and trimethoprim sulfamethoxazole to avoid pneumocystis carini pneumonia. And we maintain these treatments around more or less 6 months. Also, in the follow-up, we usually check PCR for cytomegalovirus and Epstein-Barr virus because they are very frequent. Around 40% of our children have an infection of this virus, and the first one could do severe infections, and the Epstein-Barr virus is related to the post-transplant lymphoproliferative disease. We also have to educate our children in hygiene measurements that COVID has teach us a lot about this. So our children has to use masks in the closed centers, and washing hands is very important for them. And after heart transplant, live virus vaccines are prohibited, but all the also vaccines are recommended, such as annual flu vaccine. And in the long-term follow-up of this patient, in the same graph, we can see that CAV from the 3-5 years after transplant becomes an important comorbidity. Graft coronary disease is a progressive inflammation of coronary arteries, and it is the main cause of death under transplant in the long follow-up of these patients, with an incidence at 5 years around 5 to 18%, and at 10 years after transplant, the incidence rise 20 or 40%, varying in the different surveys. Coronary disease usually is diffuse and progressive, as you can see in this image, and previous rejection is the main risk factor. Some of our children have several symptoms such as chest pain or effort dyspnea. Sometimes we can see graft dysfunction, but this is with advanced disease usually, but other times we have no symptoms and it is the cause of a sudden death. For the diagnosis, we have to do coronary angiography, so we usually do it by protocol per year, as I will show you later. And the treatment of this disease is difficult. We can try to change the immunosuppression therapy with sirolimus, and sometimes we can do angioplasty, but at the end it is the main cause of retransplant or death. Other morbidity that we can see after heart transplant, which are less severe, could be the presence of high blood pressure, diabetes mellitus, or hypercholesterolemia related to some of the medicines. Last important morbidity is the appearance of tumors. The incidence in our surgery is around 5%, and the most important is the post-transplant lymphoproliferative disease, which is mainly related with Epstein-Barr virus infection in our children. Most of them, we can use chemotherapy, and this means immunosuppression therapy, and most of them go to a remission state. So how we do the follow-up of these pediatric heart transplant recipients? If there is any urgent, such as fever, infection, rejection, their family, or their pediatricians call us to the heart transplant mobile, and they go to the emergency room in our hospital or their near hospital and contact with us in all the time. And sometimes they have to go inside the hospital in the pediatric cardiac ward if it is required. The current follow-up of our outpatients is on Tuesdays every week. We have a special consult for them for pediatric heart transplant. They come to our hospital each month during the first year and each 3 months later. All the times they come and get their blood samples exams from our consult. Balbina help us and give them. Then they go to the extraction site and we get the blood samples. In this we check the tacrolimus levels, but we also take hemogram, biochemistry, urine analysis, PCR of cytomegalovirus and Epstein-Barr virus. I will show all of them here. And we periodically take also VMP to discard rejection. And we get their analysis. They go to wait in a separated room and we call them to come to the consultant area. There we do a review with a medical and nurse explorations in the same site with ECG, echo, physical exploration, BP, weight, heart rate. We also do at the same time in the same site the multidisciplinary follow-up such as nutritionists, nephrologists, psychologists come to see the patient with us. And later, the day after, we review the results, the blood samples results, and call the family to check the change in the medication or to explain the result. As we see, the clues of a successful of a good follow-up in this type of patients is that we have the same equipment during the years. Fortunately, we have changed the echo machine, but we are the same people all the time, and we have a continuous contact with the patient families. Thank you, our heart transplant mobile phone. Also, we have a continuous contact and sharing the information and the follow-up with the cardiologists in the other TTs and other hospitals. Nowadays, with the Teams, Zoom, is easier for us from COVID time. And in this manner, we avoid to the patient to come always to our hospital to do the blood samples or the echo or ECG, and we share the follow-up with our partner. These are the protocol of the biopsy and coronariography of a follow-up. As I explained you before, it is important to check the graph coronary disease and also to check rejection. We do biopsy in the 7 days after transplant, 1 month, 2 months, and 3 months after transplant, and 1 month after the corticosteroids stop. And later, at 1 year after heart transplant, and per year during the first 5 years, and later biannual, we do coronariography, and only biopsy if we have a suspect of rejection. And all these measures of the follow-up in order to give our patients a normal life with their distension measures, but completely normal life that they could play, run, play sports, go to school, and be happy. But we have current problems, and for them, new strategies. Our most important problem is that we need more donors. We have a great donation in our country, but we need more. And because of that, we began in 2018 a VO incompatible heart transplant program. We saw that the probability of transplant was less and waiting list time mortality was high for children under 1 year, especially under 3 months of life in our country. And also during 3 years, 15 hearts under 12 kilograms were offered without a compatible receptor. Of that, my leader, Dr. Camino, met Dr. Lori West, who is the pioneer of this program, began it 20 years ago in Canada, and we began the program in children under 1 year without isoagglutinin in blood or with little titer, less than 180, and in this type of heart transplant, the unique condition for the donor is the size of the heart. This program has demonstrated the same survival, and we use the same immunosuppression therapy. The only difference is that we have a special transfusional regimen during all the life of these patients before the heart transplant and thereafter, forever. We give them a red blood cells, the same group of the recipients, but platelets or plants must be AV in order not to give them isoagglutinin in a passive. We began the program in 2018 and with the same program for the 6 centers that perform pediatric heart transplant in Spain, and we have analyzed the results with a reduction in mortality in the waiting list of 50% from 29% to 9.5%, and an increase in the probability of transplant in this group of age from 47% before the AVOI program to 65% after the implantation. What other new strategies we are working on in order to get more donors? From 2020, Dr. Jaurena has done the protocol to use DCD donors in heart transplant, and we have performed in our center 1 case. We have to do more to see the real results. In adults, it has been in our country 2 years before. And the other problem we are investigating on it is that the pediatric heart transplant is not for all the life, because the median survival of the organ is around 18 years by now. So we are doing several new students about T cells and immunological system in these children in order to achieve tolerance of the organ. and we are performing the first clinical essay in the world. And we are infusing Treg cells from the thymus of the same patient in the 7th day after her transplant in order to get this tolerance. We have no results by now. We have started this investigation the last 1 year, and we have 6 patients with this treatment included. I will show you the results in the next Congress. Thank you very much for your attention. I hope it will be useful and you understand me properly.
It was an awesome presentation, dear Dr. Nuria. The slides was awesome. The integrity was wonderful, and many thanks for making these slides and sharing your knowledge with us. First of all, I want to introduce you the first facilitator of the session, dear Dr. Ehsan Aghai, the Pediatric Cardiology Professor in Children's Medical Center, who want to welcoming you kindly. Dear Professor Aghai, we are with you.
Hello, and thank you very much, Aylar. Thanks to our precious speakers, and thank you very much for your very educative presentation. There are too many questions that my colleagues and also myself want to ask you and your team, but first I would like to ask Aylar to... Okay. Okay. There, there are so many pediatric cardiologists and also pediatricians here, and they are from different parts of the region, Middle East, especially from Iran and Iraq, and some of them are trying to build a center for cardiac transplantation in their countries. As you may know, we have two main centers in Iran that are working on pediatric cardiac transplantation. But in our university, I mean Tehran University of Medical Sciences, which is the largest one in our country, we have missed the opportunity to have this ward and unit for ourselves, and the country needs another center, you know. So after, I think, Aylar, we will go for the questions after the completion of all lectures, and then we will go for the basic questions that will help us in this way, if you agree, for sure.
Yes.
Thank you very much.
Yes.
Okay.
Thanks a lot, dear Professor Aghai. And also, I want to introduce you another session facilitator that we are honored to have. Dear Professor Asuf Saleh from College of Medicine, Suleimani University, Iraq. He is the Chief of Pediatric Group in College of Medicine in Suleimani. Dr. Asuf, we are pleased to have you.
Thank you. Really, I'm appreciate to be here, and this is a great honor of us as a College of Medicine, Suleimani University, to be part of your conference, and it's nice to have all these lecturers and teachers and professors from all over the world and participating in such a great event.
Many thanks. The pleasure is ours. I think we completely proved that science has no borders. Iran, Iraq, Spain, we all work together to make the world better place for children and make them live better. I want to ask lecturers kindly to stay with us to share the questions at the end of lectures. I want to go to the next lecturer, our dear kind Dr. María-José Santiago, a medical doctor specialized in pediatric intensive care, clinical and experimental research focused with expertise in CRRT, ECMO, and VAD. Specific research interests in hemofiltration, plasma filtration, ECMO, hemostasia, and anticoagulation. Now she is attending pediatrician in the Pediatric Intensive Care Unit, University Hospital Gregorio Moreno since 2006 from Madrid, Spain. The pediatric hospital is a 100-bed specialized pediatric hospital with a pediatric intensive care unit. The hospital is referenced in the country for the treatment of congenital cardiac patients. It is also a reference in ECMO therapy. It is awesome. Also, she is associated professor of the Universidad Complutense de Madrid since 2013. It's a great honor to have Dr. Maria Santiago with us. Dear Dr. Santiago, if you have anything to share, we are with you. If no, I am going to the presentation. Okay, so.
Presentation.
Thanks a lot. Okay, for sure. Okay, again, dear audiences, if you have any question, put in the chat section. I'm going to share the presentation of dear Dr. Maria Santiago. After that, we are again for the questions.
Hello, my name is María-José Santiago. I work in the Pediatric Intensive Care Unit in Gregorio Marañón Hospital in Madrid, Spain, and I'm going to present you mechanical circulatory support as a bridge to transplant, our experience. The objectives of this presentation are to explain how to integrate ECMO and ventricular assistance devices into a comprehensive care program for children with heart disease as a bridge to transplant, to show the indications and limitations of this technique in this context, and to present our center's experience. This is a picture of our intensive care unit with the ECMO in front of the Berlin heart machines and the Levitronics. When do we use mechanical assistance in pediatric patients? In general, when we have heart failure with high mortality risk, despite optimized conventional therapy, and when we think the pathology could be reversible with rest, surgery, intervention, or with a normally these are intermax situations 1 and 2. Extracorporeal devices provide temporary cardiac and pulmonary support to patients incapable of maintaining adequate tissue oxygen delivery, trying to avoid multi-organic failure. Sometimes in these situations, precise indications are difficult to define and there is no consensus of indications standards. The choice of one device or the other depends on previous patient's status, expecting waiting time for recovery or transplant, and also each center's experience, risk-benefit ratio, etc. The preferred mechanical assistance as a bridge to heart transplants and for long-term support are VADs. But in emergencies, like in a cardiac arrest, or when you need respiratory support, an ECMO circuit has to be used because VAD needs more anticipation and only provides cardiac support. Both treatments need anticoagulations. There is more experience in ECMO, it's less expensive, but allow patients mobility and extubations. At the end, the experience of each group and the availability is going to decide. Normally, when we need mechanical circulatory support, the first question that we have to answer is, Is the patient requiring respiratory support? If the answer is yes, we use ECMO. If no, use a BAT. If you expect a recovery in less than 2 weeks, we use a short-term device. If the situation could be prolonged, we use a long-term device as the Berlin heart. And when we awaiting transplant, BAT had higher survival rates than ECMO. And how does being supported affect transplant outcomes? The use of BAT as a bridge to heart transplantation in pediatric patients has continued to increase. In this large registry with more than 5,000 pediatric patients, currently 1/3 of patients were undergoing heart transplantations from BAT support. An increasing proportions of patients, 20%, were supported with BAT, compared with a decreasing proportion of those 4.7% supported with ECMO. Patients who need ECMO had a higher mortality during their transplant hospitalization, while BAT patients had similar mortality to not mechanically supported patients. Using BAT as a bridge to transplant has limited waiting list mortality without compromising post-transplant survival. There is another large registry, the PediMax registry, that has been enrolling patients since 2012. There are more than 1,000 patients registered. It is an important source of data for moving forward. And here they also presented results with implantable devices. And now I'm going to present our history. This is our timeline of mechanical support. In our center, since 1997, ECMO has been used in the neonatal intensive care unit. In the pediatric intensive care unit, the ECMO pediatric program started in 2006. In 2009, the first Berlin heart was implanted. And in recent years, we have also used a centrifugal pump, Levitronics, for midterm assistance. Let's start with the Berlin heart. This device is a miniature pneumatic pump connected via cannula to the patient's heart. There are different size pumps and cannula, allowing assistance to even 2.5 kilogram base. There are several studies on the Berlin heart used in Europe and USA. During the first studies, the survival was very good, but neurological complications could happen in 29% of the patients. During current studies, that number has decreased because of the changes in the anticoagulation protocols to 17%. And lately, we have used Levitronics, which is a centrifugal pump with a low hemolysis ratio that you can use for less assistance or biventricular assistance as a short-term device. Implanting a BAT restores cardiac output and end organ perfusion, and it offers the opportunity for nutritional support, extubation, and physical rehabilitation. That is very important for our patients. Now I'm going to present our results. Between May 2009 and 2021, 30 devices were implanted in our center. 18 were pulsatile pumps and 12 continuous centrifugal pumps. In 3 cases, we had problems with anticoagulation and infection, and we have to change between systems. The median age was 20 months, and the median weight was 10 kilograms, with 12 patients, less than 10 kilograms. The main diagnosis was dilated cardiomyopathy in 14 patients and acute myocarditis in 5 patients. We had also 4 patients with univentricular physiology. The patient profile is a critical cardiogenic shock in most patients before the implant. 43% had ECMO pre-implant with a median of 8 days on ECMO support, and only 4 patients were not on mechanical ventilation. The other ones has a median of mechanical ventilation pre-implant of 12 days. Most patients had a univentricular support, a left ventricular assistance in 22 patients, and the median support was 29 days. 9 patients were supported more than 60 days, and 1 patient 207 days. In 2 cases of the 22 who received only left assistance had to be transferred to ventricular assistance lately. The most serious complication is the infection, and all efforts had to be done to avoid it. We had infection in 25% of the patients with Levitronic and 22% of the patients with Berlin heart. Of kind of infection, also the infection of the cannula site insertion. Most of the major bleeding were presented in the first 48 hours. All of the patients who suffer major bleeding complications overcame, and no assistance needed to be stopped. During the running of the system, devices has to be changed because of thrombosis in a median of 3.4 times with the Levitronics and 0.8 times with the Berlin heart. Thrombosis is one of the major problems of these systems. Since 2009, the anticoagulation protocol had evolved, trying to avoid these complications. But in our case, we have to customize the local anticoagulation protocol to more aggressive anticoagulation and antiaggregation. And we have to customize the protocol. This is our protocol. And it is vital to be vigilant and to regularly check the lines and ventricles. Nurse training is essential for these aspects, as well as protocols of dressing the cannula, etc. Neurological complications occur in 43% of our patients. In 8 cases, we have an ischemic stroke, and in 5 cases, an hemorrhagic stroke. We couldn't attribute the cause of the neurological event totally to the assistance, because all of them have had a cardiac arrest or ECMO before the assistance. About the outcomes, 2 patients assisted with Levitronics improved, and they didn't need a transplant at the end. 18 patients were bridged to transplant, and 17 of which survived to discharge. The survival rate is 63%. Mortality was equal with pulsatile or continuous pump. ECMO pre-implant mortality was higher than patients with no ECMO, and patients who suffered a cardiac arrest had a higher mortality too. Conclusions. To start a mechanical assistance program, we have to work together as a multidisciplinary team to decide indications and timing in this process, sometimes very difficult. We need an hematology specialist involved in BAT to customize the anticoagulation protocol for our hospital. We have to control a lot bleeding with thrombolastography, and also we need to monitoring antiaggregation and anticoagulation. But the most important thing is the training courses with hands-on and simulation, a regular retraining of all the staff. That's the way to obtain a success for our patients. And thank you very much to them, the patients and the families, and thank you very much for your attention.
Thanks a lot, dear Dr. María-José Santiago, for your awesome presentation. If you yourself have anything to share, we are all ears with you. If not, I'm gonna introduce the next lecturer.
Thank you very much. You can introduce the next lecture, and then we can talk.
Thanks a lot. So I want to kindly ask you to stay with us for the discussion panel at the end of the session. I want to introduce you the next lecturer, dear Dr. Juan Miguel Gil-Jaurena, Bachelor of Medicine and Surgery from the University of Navarra, MIR Specialist in Family and Community Medicine at the Toxagorritxo Hospital in Vitoria-Gasteiz, MIR Specialist in Cardiovascular Surgery at the Hospital de la Santa Cruz, Sant Pau in Barcelona. Dr. Juan Miguel Gil-Jaurena became adjunct pediatric cardiac surgeon at the Volo de Hebron Hospital in Barcelona. From 2007 to 2020, he was head of the Pediatric Cardiac Surgery section. Carlos Haya University, Regional Hospital in Malaga. Since then, he is head of Pediatric Cardiac Surgery Section, Hospital General Universitario Gregorio Marañón in Madrid. It's a big pleasure to have dear Dr. Juan Gil-Jaurena with us. It's a big pleasure. Dear doctor, if you have anything to share, we are all here. If not, I'm going to share your presentation. You're muted, sorry.
Thanks a lot. You can go ahead with the presentation, please.
It's awesome. So nice. I'm going to share dear doctor's presentation. And after that, we are going to be with you with the panel discussion. Enjoy the lecture.
Hello, dear friends. This is Juan Miguel Gil-Jaurena, Chief of Pediatric Cardiac Surgery, Hospital Gregorio Marañón, Madrid, Spain. Thank you very much for your kind invitation to join you in this international meeting. Between 500 and 600 pediatric heart transplants are performed yearly worldwide. 20% are performed in younger than 1 year. The attrition rate is very similar to the adult population, with a more strict attrition rate in children below 1 year. These are the figures in Spain. The Spanish registry shows that about 300 heart transplants are performed yearly in our country, and between 15 and 30, which means 5 to 10%, are performed in kids. These are the data from 1984, the year that the first one took place in Spain. As you can see, between 10 and 35, which means 15 to 30 per year, which means at the same time 5 to 10% of the overall number of heart transplants in Spain. This is Spain, southern Spain, southern of Europe, and that's the extension of our country with 47 million inhabitants, with 6 pediatric transplant programs, and Madrid is centrally located, which is very convenient for harvesting hearts all over the country. Nearly 50% of our patients who need heart transplant have a dilated cardiomyopathy, and nearly 50% have an congenital heart disease, and among them the most prevalent is hypoplastic left heart syndrome or single ventricle overrun. Regarding to surgery, the most simple way, which is very similar to the adult population, is performed in dilated cardiomyopathy. A virgin thorax, proper connections. Once you remove the heart in the recipient, you start stitching the 5 anastomosis in the recipient. In other words, it's a pretty straightforward surgery in dilated cardiomyopathy. But let's focus about surgery in 2 items, in the harvesting and in the recipient. For sure, we take extra tissue in the donor, which means that we have an extra amount of aorta, superior vena cava, and nearly always a sheet of pericardium. If we had a look at the drawing from the rear, this is the left atrium with the 4 pulmonary veins, the right atrium with a long segment of superior vena cava plus innominate vein, pulmonary trunk with both pulmonary arteries, and most important, ascending aorta with an aortic arch from which we can see the supraortic vessels. And in the recipient, once we remove the heart, this is the surgical field we must pump into. In red, left structures, in blue, right structures. As you can see, the left atrium with the cuff pertaining the 4 pulmonary veins, a long ascending aorta, pulmonary trunk with both pulmonary branches, and rather than the right atrium, we usually perform 5 anastomosis, which means that the superior and inferior vena cava are present. We have on the one hand a simple transplant in the dilated cardiomyopathy, and on the other hand the most difficult congenital heart disease. I will depict what I would call the tips and pitfalls in this transplant surgery. Simple surgery is similar to adults in dilated cardiomyopathy. We do accept graft discrepancy, sometimes 2 to 1, sometimes 3 to 1, the weight ratio between donor and recipient. And we have to pay particular attention, what we call size matters, in younger than 1 year, and particularly in neonates, in which the size discrepancy is most striking. Let's move to the other side, to the other end of the spectrum. In a most difficult congenital heart disease, we might face a redo procedure, which means time consuming. We need to check the basal patency, particularly important for anesthetic monitoring. We might think about alternative cannulation, maybe the femoral, cervical, so as to connect the extracoronary circulations. And sometimes, after removing the heart in the recipient, we have to take down or undo some of the previous surgery. For example, a Glenn, a Lecoq maneuver, and so on. And at the end of the procedure, we might deal with adhesions, bleeding, and so on. So, on the one hand, simple surgery for dilated cardiomyopathy. On the other hand, very difficult procedures we have to schedule properly beforehand. Let's make an example. For instance, we could transplant a Fontan patient in which we have a single ventricle connected to a neo-ascending aorta. We may have not pulmonary trunk, but isolated pulmonary arteries, and superior and inferior vena cava are no longer connected to the right atrium, but on the other hand, the superior vena cava connected directly to the pulmonary artery, a so-called Glenn stenomosis, and we may have an inferior vena cava connected by means of an extracardiac conduit to the right pulmonary artery. On top of that, we may encounter some stents in the vessels, particularly in the left pulmonary artery and sometimes in the inferior vena cava. So once we remove the heart in the recipient, sometimes we have to remove extra tissue in the recipient because of calcifications, narrowing, or distortions of previous surgeries, and we have to undo some of the previous procedures. So we might face a scenario more like the picture which I show you here. A left atrium which is sometimes small and might be to be enlarged with a remnant of the right atrium. Rather than ascending aorta and aortic arch, if we need to remove all the stuff from previous surgery, calcified patch and so on, a piece of pericardium, maybe from the recipient or from the donor, as I showed in a previous picture, to patch from hilum to hilum the pulmonary arteries after removing any remnants of a previous stents. And for sure, we have to take down the glen and the extrafontan anastomosis. So this particular scenario is the most similar to the one shown before, in which we have a cuff of the left atrium, an ascending aorta, a trunk pulmonary artery rather than both branches, and superior and inferior vena cava. In a nutshell, we have to anticipate modifications in all of the structures. Left atrium, very small sometimes, aorta, thinking about the aortic arch, pulmonary trunk or branches, superior vena cava after a glen, and inferior vena cava. On the other hand, some of the patients might have been bridged with an assist device to the transplant surgery. This picture belongs to a patient with a biventricular assist device, in which we can see for sure that the ones on the most right-hand side belong to the aortic and right atrium cannula. Sometimes we get stuck in difficulties trying to re-enter the chest. For this particular issue, we have performed a very simple strategy, which is connecting the aortic and right atrial cannula from the very heart to the extracorporeal circulations before opening the chest. I'll show you a trial right now. And then placing a wide connection either in the arterial and in the venous line, we can start the extracorporeal circulation before approaching the chest, and then once we make our own surgical field, and after placing the cannulas properly in the aorta and both vena cava, without the need of stopping the extracorporeal circulations, we take advantage of this double wide connection to perform a proper extracorporeal circulation connection. Let me show, to finish my presentation, the numbers we got in our institutions. Nearly 40% of all pediatric heart transplants in Spain have been performed in Hospital Gregorio Marañón in Madrid since 1990. Nearly 50% of our transplant cohort has been performed in children under 1 year. And I want to underline this figure, 50%, in comparison to 20% in the international registry, which means that we got a double than expected amount of transplants in children below 1 year. Our survival estimation, the Kaplan-Meier chart, in the last 10 years is fairly good in comparison with the international registry, with a particular attrition in the very first year in the children under 1 year. But from then onwards, the survival estimation is very similar to the other cohort groups. And overall results can match the ones in the international registry of the International Society of Heart and Lung Transplantations. I call to your attention in a small study we performed a couple of years ago in 20 Fontan transplanted in comparison to 51 non-Fontan patients, in which you can see that both survival charts are nearly the same, which means that on gaining experience, even the most difficult surgical scenario can be managed successfully. Just to round up my presentation, I want to show you in this slide some of the milestones in our institutions. We've been performing more than 200 heart transplants in children in the last 30 years. In the last 8 years, we started with heart transplants in grown-up congenital heart patients. And in the last 8 years, we've been performing 25 transplants in Fontan patients. Recently, we adopted the immunocompatible strategy in children below 1 year, and we've performed 60 up to date. And our laboratory is performing a strategy of administering the thymic tissue after several days of the transplant for these patients. Last summer, we performed the first case of donation in circulatory death in a neonate, and the link is available in this particular link. And last summer, we performed in the adult hospital the first combined heart-liver transplant in a Fontan patient. My very last slide shows our scientific production in the last 8-9 years. Thank you very much for your attention.
It was such a nice lecture, same as the others. I want to thanks a lot to dear Dr. Jaurena, and also I forget to mention we owe a big and huge thanks and regards to dear Dr. Amirreza Hossein-Pur, who helped us connecting with this awesome team and also help us arrange this wonderful section. Dear Dr. Hossein-Pur, regards and we really have a good chance to have such a nice friend like you. I want to give up the bring up the panel discussion with dear Professor Ehsan Aghai and dear Professor Asu Faik Saleh, and also I want to introduce you dear Dr. Alizadeh, which is the correspondent head of cardiac transplant team in Mashhad University of Medical Sciences. I'm sure we are going to have a good panel discussion. Dear professors.
Thank you.
Thank you very much, everybody. I know you are busy with your schedule back there in Spain, but because we are having this session with the aim to getting more familiar with your experiences back there in Spain, and also knowing what are you doing and when have you started, and how can we go these steps that you have passed through to get success with your patients. Of course, I want to introduce myself, Dr. Alizadeh. Dr. Alizadeh is one of my best friends here in Iran. He's a very talented pediatric cardiologist, interventionist, and he's also working as the head of the transplant team in Mashhad University, which is another big university of medical sciences in Iran. So thank you very much for sharing your time. And I know, Behzad, you are very busy with your clinic, and thank you very much for your time. So as the first question, who is in charge with the team? Is the pediatric cardiologist or pediatric cardiac surgeon, or a teamwork will decide which person is suitable for the transplant and which way to go? It is an open question. You can answer each speaker that wants.
It's the work for both. The ONT, the transplant organization of our country, call us and offer the donor, and they give us the donor characteristics. And if they call us, it's because the recipient, the first recipient, is from our waiting list. If this donor is for other center, other hospital, they don't call us. But when they call us, we go to the waiting list and check which is the patient available. But when they call us, they usually tell us which is the patient, the first patient that this heart must be for him. But in our waiting list, we can change if there is any, any change in the clinical status of these patients on the waiting list. But the most of the times, we we only see the list and we do the same order. The first one, the patient that entered in the list before, in the first date, this is for him in the first order. If they are in the ABO incompatible list, and if we have the same blood type, we give for this waiting list in an emergency status manner. I don't know if you understand me, but
Sure.
when the organization calls us, this is for one patient, for the first in the list, and we together decide if the conditions of the donors are okay for our patient, for our recipients.
And who is in charge for the final decision making that in the first position before the process of the transplant begins? Who will decide that the patient is suitable to go in the waiting list or is not suitable for that? For example, you have a neonate that is affected with hypoplastic left heart syndrome, and someone will decide that this patient is not suitable for that. So who is that person?
We do, usually we do a session, a multidisciplinary session, and we decide together.
Yeah, we share all the duties. I mean, most of the burden relies on the clinicians, like the cardiologist, and at the end of the day, maybe the very last decision relies on the surgeon, who decides to accept or not the graft from the donor. But on a daily basis, we share the decision most of the time.
Okay, so Behzad, is there a same experience in your university, in your clinic, or it is different from that?
First of all, thank you very much, Ehsan, for inviting me to your session. And I do apologize because I was not ready for this session. But regarding to your question, the most important thing for us is that we have a selection committee. The selection committee have a regular, and in this week, we are deciding about the patients. We know the condition of the patients, and we know when, that which patient, for example, is at home or which is in the ICU. So there are some emergency forces for us, and sometimes there are not. But you know, the selection committee is consisted of many professors from these surgeries, from those surgeons, the clinicals, from the anesthesiologists, and some doctors from the cardiologists, and some for example, even the nursing team. They know everything about the patients, and they know the conditions, and we are connecting with these patients, the recipients, all the recipients. It means that week by week, we know the conditions. So the selection committee, when we have a donor, those that we call here them the harvest team will announce the patient that, for example, we have a harvest, we have a donor with this condition and with this, for example, particular weight, particular height, and particular situation. So first of all, from the selection committee, one or two of the cardiologists are visiting the patient, the donor, and they know that from the list, from the top list, we know that which patient has the same, for example, weight, the same, for example, the condition,
characteristics.
And the characteristics, all the characteristics. We have done them before, and for example, we have measured the PI, for example, PI pressure. We know everything about the diameters of the LA, diameter of the LV, diameters of the aorta, diameter of the, for example, pulmonary. And you know that it's in the vast majority of patients with very, very diversity from these dimensions. So we are deciding this patient according to the severity of the condition of the recipient, and also from the physical condition that we have, we are in contact with. For example, if you have a donor, for example, he or she is 10 kilogram, we are deciding to check it for the patients, for example, that are, are 8 to 7 kilograms. But at the same time, we may have some patients in the list that they are, for example, are 25 kilogram, 30 kilogram, and these are not good matching with these. So the selection committee knows everything about these conditions. So we are coming together through the night, through the midnight, via the, for example, most of the times, WhatsApp and some from the Zoom meetings. So we again come together, from the surgeon, from the cardiologist come together, and we decide that which patient from this list is most suitable and which is the most urgently that we can decide for it. So in this situation, we decide it all together, even the anesthesiologist, the cardiologist, and the surgeon. Sometimes the surgeon says that, no, this aorta is not suitable for me because, for example, it's TGA or it's, for example, something like that. But most of the time, we come together through a meeting, through the Zoom, WhatsApp, and so on, and so decide which patient have to go, and we call it for tomorrow operation.
Okay, so I get it that both centers goes for a teamwork to decide the which patient is suitable for the transplant procedure. Yes, the second important question is that how can we train, and how much time does it need for the first patient to go into the operating room for the transplant, for the training of the team, you know, especially the nurses. How can we get them trained? For example, in Tehran, we are in lack for a training team. You know, can we use online courses or something like that to train our team, or we need to send them, for example, to Mashhad or somewhere else to train them? And how much time do you think each nurse or each physician needs to be trained for that procedure?
Well,
or a Spanish friend?
Yeah, it's a very difficult question, but it depends on those guys that you want to teach them. Sometimes you have a good surgeon, and I know that there are lots of good surgeons in your center that they would be able to do that very easily, very fast. But sometimes you are going to start in a new center that you are not familiar.
You know, Behzad, we have a very good team that works on adults just nearby, but we do not have a team that works on pediatric group. So can we use adult population to train our nurses and physicians? Is that a correct concept that I have?
Maybe yes, but I want to tell you something that is very important through the ICU. You know, the total operation time is not so much, and everything starts in the ICU for you, because the operation is the most easiest time and the most easiest part of this section. After that, you have to take this patient in the ICU, and from that time, everything is now starting. One of the most important member of the team is the clinical pharmacologist that you have. You have to give many drugs to your patient. Clinical pharmacologist will help you from the interaction of the drugs interaction, and your nurses have to be familiar with these kind of interventions in the ICU. So I think that it's one of the most important point that you have to pay attention to, that is ICU team, as the ICU training and ICU nurses. So it is very important to have a very good team working in the ICU, maybe from 2 days, from 3 days, from 1 week, that all of them have to come together and to do that. So your nurses are the most important, the pharmacologists are the most important, and the ICU meds. So I think that yes, your nurses have to be sent. It's not you cannot do something from Lebanon or something like that. And they have to be hands-on with these kind of situations in the ICU.
Can I ask the same question from Dr. Maria?
Yeah, I think you are talking about ICU that actually they work with cardiac patients, okay? No, if it's an ICU that actually works with cardiac patients, that they have congenital, post-operatory of congenital cardiac surgeries, I think a transplant is a new step, and they are more unstable patients. No, it's true, the first hours, and there are new drugs that you have to know, but it's something that people can learn. It's not it's nothing very difficult for well-trained nurses in a pediatric intensive care unit. No,
Dr. Maria, as we are talking right now, we have the chief of staff of pediatric nurses, pediatric cardiac nurses here in our hospital with us. He's in the audiences and he's listening to what we are talking about, and he's very talented and he's very experienced working with the congenital patients. So you think that we can train them, and there will be a new step for them, but they can handle the patients easily, much more easier than the other nurses that are working in the other fields of the pediatric. Yes.
Yeah, okay. Because the first 2 or 3 days of a cardiac transplant are they have to be there, and it's very challenging. But
okay, and do you have a separate ICU for the transplant patients, or you are using the same ICU that it is used for the congenital patients that are post-op? Are they separated, or you are using the same facility? They are separated.
They are all together.
Okay. Because we are in the lack of a space here, and we are working in our ICU to manage the patients from the transplant operating room into the same ICU with the patients that are post-op, that are getting post-op care for the congenital surgeries. And how many cardiac surgeons are dedicated to the transplant in your center?
Well, there are 4 cardiac surgeons in our unit, and we are usually 2 of us on call every day. So the ones on call are who perform any casualties, including heart transplants. We are very linked to the adult hospital, and most of the staff in the adult service of cardiac surgery have got some fundamentals in pediatric surgery. So we are very lucky because most of the harvesting are performed by our colleagues. And if you take into account that the figures of heart transplants in the adult population are 5 to 10-fold times, they are really used to perform either heart transplant or either to perform harvesting. So we are in a good coordination with them.
Also, there is a question that I want to ask you. Are you aware of any other cardiac transplant centers that are working right now, or you are working on in your region in Iraq and other Arab countries?
Thank you, Dr. Hassan. Really, thank you for Spain team to give their experience with the cardiac transplantation, and really your team in Mashhad, you are doing very good job. Really, I want to speak about Iraq, our region, because, we have a lot of patients that need that. But, we start first with cardiac surgery, especially in the north. I'm in the north. So we started with the procedures for those who in need. So really the program of the transplantation is, we are way behind it. Why? Because, we are taking care of those procedures that still is not done. So that's the problem in Iraq as all. So there was an intention in some centers in the middle of Iraq to start with. But, Dr. Hassan, there are so many problems before starting with the program itself. You should educate people. First of all, you should try to educate people how to donate their hearts for the other patients. That's one. This is very important because we should start with first from medias, from religious type. Our area is different, so we should work on that. That's very important, because when you start with such a program, very big program, you should start with the mind of people. So you should change the people's mind about what the life is, and how can you donate your heart, your kid's heart, to other people to make them to live. So that's very important. This is first one. Second, you should change the legislations. You need to change so many legislations. That's this is from parliament, from everywhere, from the people around, the authorities, to convince them for such an action. So that's very important. So starting this program, it's very primitive in Iraq, and we are looking forward for that, but it needs a lot of work for that. Thirdly, I want to add that when you transplant your patient, so what's the hope behind? That's very important, because if you have no good follow for those patients, you will lose them. You should take care of them, especially. And the community here is very crowded, and people want to be with each other. It's not somewhere else. So this program should be in some way educating even after a transplantation itself. So that's make us way behind.
I know that you are building a new hospital in northern Iraq, and I know you in person, and I'm sure that you will go through that barriers, and someday you will have your own transplant center in Iraq, the first one, because I know you, and I know your capabilities, I know your personality. You are very talented and very experienced. I believe in you, and my team in Iran also believed in you. I should mention that Behzad is also working in one of the most religious parts of Iran, and he succeeded in doing great things.
We should
very nice.
We should learn from him. We should have we want. That was my question to Dr. Behzadi, that how he succeed with it, because we need to learn how to pass this barrier, this religious and community barrier.
Also Behzad, just like our Spanish friends, is open to share his experience and knowledge with others. I know Behzad in person, and he's a very good friend, and he's a very good teacher also. So just $1 million questions from our Spanish friends. How much does it cost for a patient from the beginning of the procedure until the day that he or she is released from the hospital? How much does it cost? And is it cost beneficial for a country like Iran, that it is somehow restricted with sanctions. How much does it cost in Spain for a patient to be released with a good heart, good transplanted heart from the hospital?
Nothing.
Well, I'm afraid we are not
Really?
able to answer that question because we have a public system and we don't have to pay fees when we get to the hospital. Not even for surgical procedures. And so, honestly, we cannot answer that question. But coming back to the previous speaker, I think that he got the clue, which means that transplant it means a lifelong adherence to treatment, which means at the same time a close follow-up. That's why Nuria started with this session of his. I mean, she was the one to start the session of heart transplants. And on the other hand, anyone who wants to start a transplant program needs to involve the media, the government, because donation is really the clue. I mean, we can do all these things because we are lucky on having a high rate of donations in our country, in Spain. So if we take that for granted, I mean, it's our endeavor and honor trying to do our best and getting the chance of our patient to have a graft of any time.
Okay, thank you for your nice
I want
response.
to add something.
Sure.
Ehsan, I want to add something about the cost in Iran also. We also have we have free of charge for the patient. It's a very expensive cost for the government, but none of the patients pay anything. But something that is very important is the follow-up of patients. So most of these patients are following up with the social workers that we have here. And these social workers are connected to many NGOs from that those NGOs can help these kind of patients. Without these NGOs, most of them cannot follow up the patient. So it is very important to have this ring of your chain. If you don't have this ring of your chain, you will not be succeed, because the follow-up of these patients are very important. You know, when you are going for a transplantation, for example, for a 7-year-old baby, 7-year-old children, 7-year-old girl, you want to do something for a life around 70 years, 80 years. So you have to be able to do that for a long time. So in these situations, you have to rely on the donations and the charities and also the NGOs. So we are some kind of NGOs here that are connecting to these social workers that we have, that they continue the process and they know everything about this person of the for example, the heart and they regularly come back to these to the clinic by these NGOs and by these social workers. So without these social workers, you will not be succeed.
Okay, because we are in the shortage of the time, I want to ask a favor from our friends in Spain, Dr. Maria, Dr. Nuria, and Dr. Juan. Is it possible for you to give us your valuable time in future so we can build a session especially for more detailed discussions on cardiac transplantation, and we shall have more of our team here and we will discuss it more. Is it possible for you to give us your valuable time in future?
Yes,
sure.
Thank you.
Sure.
Thank you very much. I know you are very busy. We are more than honored to have you with us. Your smiles is so valuable for us. You know, we hope we shall meet in future in person. You are invited to Iran anytime that you want to come, and you will be our guests of honors here in Tehran University, just as Asu, that is our good friend, Dr. Asu. Very soon we shall meet in Tehran or in Soleimani.
Yeah. Thank you.
Mashhad, also Mashhad.
Also Mashhad, yes, yes, sure. Thank you, Behzad.
It is
Thank you very much.
a very nice,
you,
thanks a lot. It's a very nice pleasure to have all of you. Thanks a lot, dear Dr. Alizadeh, dear Dr. Asu, dear Dr. Maria, dear Dr. Juan, and dear Dr. Nuria for your valuable times. It was my really good pleasure to be a part of this session. Just as a momentum to this session, I want to take a screenshot of participants. So keep smiling and steady state on your seats. Thanks a lot. If you don't have anything to add, take care. Have a good time.
Take care. Thank you. Thank you very much. Bye-bye.
Thank you. Thank you.
Bye-bye.
Thank you
Have a good night. Have a good day. Bye-bye.
Bye-bye.
Thank you. Bueno, está muy bien las charlas, tanto a ti.